All right, welcome. Have everyone come in and we'll get started. Apologize for a few minutes delay, but we're really excited to be back here in Pittsburgh for a really important Pancreas Fest meeting. This is the 20th anniversary of Pancreas Fest. So that's a really exciting celebration. And I don't know if I see Dave in the audience yet, but of course, credit to Dr. Whitcomb, who had the vision to start this great meeting 20 years ago. Thank you for those of you who were able to join us at the kickoff reception last night, and thank you to Cincinnati Children's for sponsoring that for us. We have a really exciting session ahead of us. As always, this is such a great meeting that brings together clinicians and scientists in a smaller setting where there's a lot of opportunities for collaboration and networking. We have a number of invited speakers and sessions today. We'll also have the abstract poster session this evening at the end of the sessions, and we will be presenting in the business meeting this afternoon. Please come to that. I know it sounds not very exciting, the business meeting, but we will be presenting the Mentor of the Year Award from CAPER, and we will also be featuring some of our best abstracts from our CAPER scholars, and I think you'll really enjoy that. We have lunch served today, courtesy of one of our spotlight sponsors, Immunovia. That's located in the exhibit hall right out here, where breakfast was also served. Please download the app. There's an app for the Pancreas Fest meeting. It's under CVent. So you go to CVent, download CVent, and then you actually search for Pancreas Fest 2025 to find that. You'll want that because it has the session details, which are also available online, but it has your ability to claim CME credit and your certificate of attendance, and it will actually feature the recorded sessions for 90 days after this are available there online. We also have a social media tag, hashtag PancreasFest25. So please share your experiences, your photos, your takeaways. And please visit our exhibitors. This meeting doesn't happen without our sponsors. We have a number of sponsors. Our diamond sponsor is Imagine Pharma. We have gold sponsorship from Cincinnati Children's, Nationwide Children's, and Vivus, and silver sponsorship from Nestle, and bronze sponsorship from AbbVie. So we thank those sponsors for allowing this meeting to happen. My co-chair for Pancreas Fest is Randy Brandt, who I think all of you know and is here in Pittsburgh. So I want to turn it over to him to welcome you to Pittsburgh.
Thanks. I can tell you, it was 18 years ago that Dave Whitcomb brought me out here, and then so I've been to a couple Pancreas Fests in Pittsburgh. The one thing I was warned, so those people that drive in here, is there's a thing called the Pittsburgh left. So when you're on these small, narrow streets, don't immediately shoot through if you're going straight, because the first car is going to take a left-hand turn on you. So it doesn't always happen. They don't know, but you have to be very careful. That was the most valuable piece of advice that I was probably given. But the second one, which you're all experiencing, and I'm sure it may happen in your seasons in your cities as well, is that there's two seasons in Pittsburgh, either winter or construction season. And boy, and this construction has become year round. So we will hopefully, I don't know if it's 2027's when the tower's supposed to be finished. So we're all hoping that the next time you come back, because every other year it returns back to Pittsburgh, we'll have that completed. I just wanted to welcome you all here. The restaurants are great. It's great seeing people that come back year after year. We greatly appreciate your support. And if you have any issues, I'm usually hanging around in the back where I'm happy to give you the perspective. And there's several other people that are home based out of Pittsburgh that could help you as well. So let's hope I know it's going to be a great meeting. Thanks.
So with that, we'll kick it off to our scientific session. So if I can introduce our moderators this morning, Dr. Guru Trichodanathan from the University of Minnesota, Dr. Yasmin Hernandez-Barco will be presenting our speakers. One small note for the speakers for this first session, please just say next slide when you need your slides advanced. Thank you so much. Can you hear me? Can you hear me this way?
Can you hear me if I speak very loudly? Or you cannot? My voice is not as loud as my daughter sometimes thinks. So with our first session, it's clinical perspectives in pancreatitis management. I'd like to introduce our first speaker, Megan Petersack-Cannon. She's a pancreatitis patient advocate and currently serves on the CAPER Board of Directors. And she will be giving a talk entitled The Patient Perspective, Avoiding Delayed, Misdiagnoses, and Variable Standards of Care.
Good morning, everyone. As was said in my bio, I'm Megan. I'm here today as a patient advocate, and CAPER board. Thank you to the planning committee for giving me this opportunity and going first so I don't have to be nervous and everyone's really alert. Now, I normally wouldn't add these next few details to my bio in any other setting, but I know there's some curious pancreatologists out there. So I have the PRSS1 mutation. I was diagnosed as a child, and I had a Pusteaux procedure at the Children's Hospital of Philadelphia when I was 8. I also have a 6-year-old son who unfortunately shares this mutation with me and has had many, many pancreatitis attacks in the last few years. So suffice it to say, I have a lot of experience with the disease. Many would say too much experience. But my talk today is not just about me. My goal is to highlight some of the broader trends in the patient experience that Mission Cure captured in their recent research. Specifically, I hope to cover 2 big headlines that emerged from this report. 1, delayed and misdiagnoses, and 2, variable standards of care. While I know these headlines come as no surprise to anyone in this room, I hope to illuminate the tremendous impact these challenges have on patients and inspire some conversation and collaboration around improving the patient experience. Slide. The first headline, delayed and misdiagnoses. For this, I'm going to play a very short video that's an excerpt from Mission Cure's recent gala, highlighting one patient's experience with this common challenge. Play. Slide, play.
When I was about 8 years old, I started getting these spasms in my stomach. They got sharper and sharper and sharper to the point where I couldn't breathe and I'd be sweating. I would run to my parents and say, it's starting. And they would literally throw me into the back seat of the car and rush me to the emergency room. And they'd give me a pill and told me it was growing pains. One time I got the pain when I was eating, and that pain pretty much persisted for about 6 weeks. Because I couldn't go to school, I couldn't go outside, I couldn't eat anything. I got real weak. The gums in my mouth turned white. And that was pretty much the way my life was until I started getting a little older. And then one of the doctors said, oh, I see the problem. No, no tests at all. He said, the problem is you have an ulcer. And then they put me on Tagamed, and it didn't help. But then the next major stage was probably in my early 50s. I had my annual physical exam, and I'm sitting in the doctor's office, and he came in reading my chart, and he just kept saying over and over, I can't believe what I'm seeing here. You're in great shape. You work out every day. You don't take drugs. You don't drink a lot. And I got really scared because I thought he was going to tell me I had cancer. He says, your pancreas is completely calcified. It's destroyed. You must have had like a hard attack at one point in your life. And that pretty much did all the damage. It would have been like a horrible stomach ache, probably when you were about 10. And right then I think I almost fainted. I said, yeah, I was 8 and I had a horrible stomach ache for about 6 weeks. I said, this all makes sense now. And it was really emotional. I said, this has made my life miserable for 40 years now.
Now, you may be thinking Ted's story is a product of the era in which he grew up. This is ancient history in terms of where the field is now. However, the recent Mission Cure research shows that way too many patients are still experiencing these delayed or misdiagnoses. Patients are going 5, 10, 15 years without a proper diagnosis. And as any patient can tell you, those years are painful and traumatic and often involve a slew of misdiagnoses and sometimes some unnecessary or even harmful interventions. Slide. Patients report being misdiagnosed with recurrent stomach viruses, constipation, IBS, diverticulitis, and the list goes on. If I was brave enough to use live technology in this setting, I would have you all add to this word cloud because I'm sure in your own practice you could add many to this list. I have personally connected with a lot of parents in the pediatric pancreatitis community who report having babies and toddlers who were not eating, who were crying all the time, and they were told by pediatricians, oh, your baby has colic, or it's a sensitivity to baby formula, or just common stomach aches that all little kids get. When I brought my own son into the emergency department, writhing in pain as a 1-year-old, and shared my family history, I was told it's pretty unlikely he has pancreatitis, and it's probably intussusception. And this is despite the fact that it was the same hospital where I was diagnosed 30 years before and had the genetic testing to show for it. So I had to fight to get a lipase ordered, and it came back at over 20,000. That number still hits me really hard, and as much as I usually enjoy being right, that was not one of those times. And while my knowledge helped my own son escape those years of misdiagnoses, I can't help but think what is happening to patients who don't have that knowledge. Slide. So what can we do to reverse this trend and spare patients years of suffering? Now you may be thinking, Megan, you're up there preaching to the choir. The people in this room here are spending part of their summer nerding out at Pancreas Fest. I know some of you have the Pancreas socks and other gear. Clearly, no one in the room here is going to miss a pancreatitis diagnosis. But it's for that reason, the knowledge and expertise that you hold, that patients need you to play a role in what happens to them before they land in your office. We're sure many of you are already working on this at your own institution, so we hope you'll come to the mic during the Q&A and share some best practices. For now, we have 2 asks. 1, work to educate those frontline providers like ED physicians, primary care physicians, and GIs. And then as a second one, and more immediate next step, Mission Cure here today has a diagnosis toolkit that they would love some feedback on. So feel free to mark those up or follow the QR code to provide feedback on that. Slide. Now, some patients are lucky enough to get a quick diagnosis. I was diagnosed right away because my dad and sister had been diagnosed in the same year. Very rough year for my mom. But when a patient gets a diagnosis, they face the next hurdle in the disease, which brings us to our second headline, which is variable standards of care. In the Mission Cure report, patients and caregivers reported feeling hopeless and extremely depressed when they got the diagnosis, but then still left appointments without a treatment or management plan. They relied on fragmented online resources and support groups, and you all, I'm in those support groups. They are very dark places on the internet. But people are really just so desperate to get answers to their questions. Patients also noted frustration with specialists delivering conflicting advice, attempting different tests, scans, and procedures that didn't always relieve suffering. My own experience with the disease has followed a similar pattern. Over the last 30 years, I've gotten opinions from 5 of the National Centers of Excellence for Pancreatic Care. Now, some of you are sitting there going, wait, does this lady look a little familiar? And maybe I do, because I have flown across the country desperate for a second opinion and help in managing the disease. In many of these centers, I've seen more than one pancreas specialist or related specialists in nutrition or pain management. And throughout the journey and all the opinions, I've been told such conflicting information, sometimes within the same institution, that I often leave appointments feeling defeated and overwhelmed trying to piece together a care plan for myself. Here on the next few slides are just a few of the conflicting opinions I've received. Slide. Okay, so on the one hand, I've been told for surgeries, your pancreas is a ticking time bomb. For pancreatic cancer and chronic pain, you must get the TPIT done sooner rather than later. Same institution, next appointment. Your life will never be the same after that surgery, and it should really only be seen as a last resort. Slide. Other surgeries. A drainage procedure, like the one that I got when I was a kid, can reduce flares and overall pain. So, that's one option. On the other hand, yeah, that was 1993 when you had that done. We don't really do that anymore. Drainage procedures don't really work. Slide. Endoscopic procedures. So I've been told you really need a scope or an ERCP to figure out what's going on in there so we can help you. On the other hand, I've been told you have some really unique anatomy and your pancreas is very sensitive, so you should not have a scope unless it is absolutely necessary. Next slide. Daily medication, pancreatic enzymes. This one should be a simple one. I've been told you should have been on these enzymes from the moment you were diagnosed. They can help relieve pain and absorb nutrients. On the other hand, I've been told, well, you don't technically have EPI yet, so you can take them if you want, but you don't really need to. Next slide. Diets. Ooh, I could have a lot of slides on this one, but I've been told, well, there's no research to support one specific diet, so you can try, just, try to eat healthy. On the other hand, I've been told, oh, diet plays a huge role. You should try the low-fat diet, the low FODMAP diet, an anti-inflammatory diet. These might help reduce pain or flares. I've talked to other patients who have gotten this conflicting information about alcohol. Hey, you could have wine here and there, or no, absolutely, you should never drink any alcohol. Next slide. And then finally, as I'm getting older, thinking about pancreatic cancer screening, since I'm in a higher risk category, I've been told, listen, you have a lot of calcifications in your pancreas. There's no way we could detect cancer effectively for you. On the other hand, I've been told, if you get a yearly MRI, that's a great pancreatic cancer screening. I could probably add 15 to 20 more slides with the same pattern from just my own experience, much less going through these contradictions as an advocate and caregiver for my son. The impact of this variable care is immense. It adds to the anxiety and stress of having a chronic illness. It reduces patients' trust in doctors and the larger medical community in general, and it often leads to lots of unnecessary pain and suffering. Slide. So, what can we do to reverse this trend? First, I want to acknowledge two hard truths in the field right now. One, that there is currently no gold standard treatment for pancreatitis. And I'm really grateful to many of the people in this room who are working hard to change that. But until there are better tools, I understand that's not straightforward. Two, there's a good degree of variability in the umbrella of pancreatitis. So even in my own family, we have the same genes, but we have seen very different disease presentation and progression, which makes it difficult to have one care plan that works for everyone. And that's why what we are, as patients, are advocating for today is not a one-size-fits-all plan for pancreatitis patients, but rather for the standard to be a comprehensive care plan in and of itself. For too many of us, myself included, the standard of care is go to the ED if you have pain. I might see you in clinic every 6 months. This reactive approach only heightens anxiety and does nothing to manage the symptoms and struggles of this disease. What we all need are plans for nutrition, pain management, topics the other speakers on today's panel will address, regular imaging and blood work, what to do if we have extreme pain at home or mild pain at home, what to advocate for in the emergency room, support and planning for managing disease over a lifespan, including through illness, life changes. I did have a big breakfast, but it's not just that. I am pregnant as well. And so being a patient who has a very complex GI history and then being pregnant just makes having a care plan that much more important and that much harder to get. So even as I've struggled as an adult patient to get this kind of plan in place, I have been encouraged by the plans my son has received as a pediatric patient. Slide. Here on the screen, you can see that he has a detailed plan of care written by his doctor that we bring with us to the emergency department, complete with a QR code for the most up-to-date pancreatitis pathway. This may seem like a simple thing, but it has spared him and us as his parents so much anxiety and stress to know exactly what should be done for him. And this is just the tip of the iceberg in terms of his care plans. He has a plan for home to manage pain and flares, plans for ongoing monitoring of his health and pancreatic function, nutrition guidance, a plan for using coping strategies thanks to a GI psychologist. And on the right there, you can see Teddy's boo-boo plan, which is every time he has to get an IV placed, this is the plan he has in place to help him cope with that. We're so grateful to Dr. Brownell, see you out there, shout out, and the entire team at CHOP for this level of care. And our hope is that more patients in this community can have the comprehensive care plans that they deserve. I'm sure there are many great plans and approaches to this out there, and I hope you'll lean into the answers part of the Q&A, especially since I'm not a doctor, so won't be able to answer that many questions, and share the ways you and your teams are working to make sure the patient experience improves. I want to conclude by thanking the CAPER board and the planning committee for elevating patient voice here today. And slide, and on behalf of my son Teddy here, looking super cool, my whole family, and the pancreatitis patient community, I want to thank each of you for your dedication to treating diseases of the pancreas and working to improve the quality of life for people like us. Thanks so much.
Thank you, Megan, for voicing your patient perspective and for everything you do for the CAPER board. It's my great honor to introduce our next speaker, who's also a great friend of mine, Jorge Macchiato from University of Michigan, and he's going to be talking about refractory pain in pancreatitis. What is next?
Thank you so much, Guru, for the kind introduction. Thank you so much to the organizers for the opportunity to present today. Megan, that was a great talk. Thank you so much. So we're going to talk about refractory pain in pancreatitis. Next. These are my disclosures. Next. We're going to first review about the definition of what's refractory pain in chronic pancreatitis. We'll briefly review about the pain mechanisms in CP, and we'll spend most of the time reviewing about the treatment approach for refractory pain in chronic pancreatitis. So how do we currently manage painful CP? This is a summary of what we consider a standard of care for most of our patients. Initially, we start with lifestyle modification, quitting alcohol and smoking, non-opioid analgesics, and ruling out other etiologies for pain. Now, if the pain persists, we typically try to use gabapentinoids, antidepressants, sometimes opioids, and selectively endoscopic or surgical procedures. Next. But what is refractory pain? Actually, there's not a good standard definition of this, but we can define this as persistent pain despite the use of lifestyle modifications, non-opioid analgesics, a gabapentinoid, an antidepressant, and endoscopic or surgical intervention when warranted. Next. But how common is refractory pain in chronic pancreatitis? Because there's no definition, we don't really have a good estimate of it, but we can approximate to that question by looking into a couple of studies. One was a retrospective study of UPNC that had a follow-up of over 10 years in near 300 patients, and approximately half of these patients had a persistent pain despite using interventions and even being on opioids. Now, if we look at the ESCAPE trial that compare early surgery with endoscopic drainage in very well-selected patients with obstructed pancreatic duct, over 50% of the patients had persistent pain even at 18 months of follow-up. So we can estimate from these studies that approximately 50% of patients have refractory pain to the conventional interventions that we use. Next. But why is this a problem? One of the major issues is that approximately half of the patients with chronic pancreatitis are on opioids, as demonstrated in a recent study published by the PROCEED Consortium. And among these patients on opioids, half of them are on scheduled opioids and strong opioids. And due to this has positioned chronic pancreatitis at the top of the ambulatory prescriptions for opioids among all the different GI conditions, even above chronic liver disease and Crohn's disease, as demonstrated in a recent study using administrative data. Next. But why is pain refractory in chronic pancreatitis? One of the major reasons is that pain mechanisms are very heterogeneous within individual patients. We know that a subset of patients are going to have nociceptive pain that is solely due to peripheral tissue damage. Now, these patients probably are going to respond better to non-opioid analgesics and may respond to endoscopic or surgical procedures for a stricture or a stone or a pseudocyst. However, we know that there's a subset of patients that either have a shared additional mechanism or independent mechanism related to either neuropathic pain that refers to peripheral nerve damage or to nociplastic pain. That is the new term coined by the International Association for the Study of Pain to refer to centralized pain. Now, these type of pain are going to be the ones that are likely going to be less responsive to the different interventions that we conventionally use, and are the patients that are more difficult to treat in our clinical practice. Now, there are tremendous efforts to try to differentiate among these pain mechanisms using tools like quantitative sensory testing and other tools. And that's very important because that may allow us one day to do precision medicine when we want to treat a patient that is in front of us in the office. However, currently, we don't have those tools available, and we have a trial and error approach that we use in clinical practice. Next. So just briefly about nociplastic pain, this refers to increased activity in brain regions that are involved in pain and decreased activity in areas that have pain inhibition. So there's clear evidence in chronic pancreatitis that there are changes in the brain structure and function through different studies that have been done, demonstrated that there's presence of nociplastic pain. Next, and if we think about this, chronic pancreatitis nociplastic pain is like having an amplifier that is making you sense low signals or even the absence of signals, and patients perceive, despite that, the presence of very severe pain. Next. What are the treatment options for refractory pain in CP? Here's a list of different therapies classified by mechanism of action. Some patients, for example, with nociceptive pain may respond to decreasing the pancreatic drive by using uncoated enzymes or even CCK inhibitors. But more commonly, patients are going to have nociplastic pain. These patients, typically, we can use non-pharmacologic therapy, such as cognitive behavioral therapy, exercise, or yoga. There are also external neuromodulation devices that can be helpful for this matter, such as using acupuncture or transcranial magnetic stimulation. For patients with neuropathic pain, sometimes we can opt for using direct nerve interventions, such as celiac plexus block or splanchnicectomy. And there's other therapies that are not in any of these mechanisms that can be helpful, such as antioxidants, ketamine, and TPAIT. We're going to discuss about some of these therapies that have been backed up based on clinical trials. Next. So to start, cognitive behavioral therapy, CBT, provides patients with self-management strategies that help them coping better by having behavioral changes that are consistent with improved health. And this has shown to have high-quality evidence for managing chronic pain conditions. Now, within chronic pancreatitis itself, this has been studied in a pilot RCT of 30 patients in which compare giving CBT for 8 weeks using a web-based program. And this was compared to assigning patients to a control group for wait list. And when they compare these two groups, the group that was assigned to CBT has significantly better outcomes, less pain intensity and pain interference, even if you look with a threshold of 30% improvement or 50% improvement. However, notice that there's still a fraction of patients who do not benefit of this. And this is probably because the patients who have nociplastic pain are going to be the ones that respond the best, but patients who do not have this type of pain may not respond very well to this therapy. Again, bringing up the concept that we need better precision medicine tools when we treat patients. Next. Yoga, for example, was a study in an RCT of 52 patients conducted in India a decade ago. And in this trial, they compare 1 hour yoga sessions 3 times a week for 12 weeks with a standard of care. And you can see that the yoga group did significantly better. They had improvement in different domains of quality of life, including bodily pain. But in the control group, you don't see any significant difference to any of these domains. So again, this was a small study and requires further evaluation in clinical trials. Next. Pancreatic enzymes, of course, we use them for exocrine insufficiency, but one question is in patients who do not have exocrine insufficiency, can they improve abdominal pain? And the hypothesis is that the enzymes can inhibit pancreatic secretion, potentially reduce intraductal pressure, and therefore improve abdominal pain. This was a study in an all crossover RCT of 19 patients, in which patients were assigned to either 1 week with non-enteric coated enzymes or placebo. And the group with the enzymes did significantly better with less pain severity. However, subsequent studies haven't been able to replicate this. And when we look at this into meta-analysis, combining patients who receive coated or uncoated enzymes, there's not a significant effect on pain. However, this is a low-risk intervention that may be considered for patients selectively who have nociceptive pain, for example, because it's unlikely that those with centralized pain will respond to this. Again, bringing up the issue of why we need precision medicine approaches. Next. Following the same concept of decreasing pancreatic secretion, people have used CCK inhibitors. This is one called Proglamide that was studied in an open label trial of 8 patients. Patients received Proglamide 3 times a day for 12 weeks and demonstrated that there was a significant improvement in pain severity, COMPARES-F, and PROMIS. Now, this definitely will require additional evaluation comparing with placebo to really understand the effect of the treatment. And such a trial will be undergoing in the near future. Next. Antioxidants have been used for many years in clinical trials and evaluated with the hypothesis that chronic pancreatitis can cause oxidative distress, trigger zymogen activation, and inflammation within the pancreas. And here is a summary of the 2 largest trials that were conducted many years ago and published in Gastro. And these 2 trials provided inconsistent results. Both trials gave antioxidants daily for 6 months using a cocktail based on methionine, as you can see at the bottom in the blue box, what it contained. And in these trials, they used different endpoints and also had different populations, which may explain the differences within results. But what is important to highlight is when they combine these results with other studies that have been published into meta-analysis, there's, again, inconsistency within the effect of the intervention. Now, my take on this is that this is probably low-risk intervention. There are adverse events such as constipation, nausea, reflux, but could be considered selectively in patients, especially that may have nociceptive pain. Next. Let's switch gears to neuromodulation modalities. Acupuncture has been used widely for chronic pain and demonstrated efficacy in some patients with different types of chronic pain. In chronic pancreatitis, this was studied in a single-blinded, sham-controlled crossover trial of 15 patients conducted in Denmark. In this study, they gave a single session of acupuncture, which demonstrated a superior efficacy as compared to sham immediately after of giving the acupuncture. But when the patients were assessed at 24 hours or 7 days, there was absence of efficacy, meaning that this is a very short-lasting effect. However, this was only one single session. And many of the trials done for chronic pain have done this with repetitive sessions of acupuncture. So I think that such a trial is needed in the future to really understand if giving more frequent acupuncture sessions can improve efficacy in chronic pancreatitis pain. Next. Repetitive transcranial magnetic stimulation, RTMS, is a technology that uses magnetic pulses to stimulate different areas of the brain and has shown to be effective in some chronic pain conditions. This was studied in chronic pancreatitis in a parallel RCT conducted in Boston a few years ago of 17 patients. And in this trial, that they gave RTMS sessions 5 days a week for 2 weeks, showed to be superior to sham immediately after finishing the 2 weeks treatment. But moreover, if you see at 6 weeks, 7 weeks, and 8 weeks, there was still a persistent effect of the RTMS in the analgesic effect as compared to sham. While this is very promising, this definitely needs additional studies. And since this was published over a decade ago, this hasn't been replicated or evaluated again. Next. There are several other neuromodulation modalities, such as transcutaneous vagal nerve stimulation or spinal cord stimulation. But when they were evaluated in different sham control crossover trials, these haven't shown to be effective for pain relief. However, the most important reasons for this may be due to the small sample size, as you can see, ranging between 6 to 20. So there's definitely a lack of power in these studies to talk about efficacy. And future efficacy trials are needed within this field. Next. One technology that we're using at the University of Michigan is transcutaneous electrical acuostimulation, TEA. This device administers electrical current via surface electrodes that we locate at acupoints that you can see in the left lower figures. One advantage of this over traditional acupuncture is that it doesn't need needles or a certified operator to administer the treatment. Patients can use it at home as outpatient, and we can even teach this remotely. And this has shown to be safe and effective in different painful GI conditions such as IBS, dyspepsia, and even acute pancreatitis. Next. So we evaluated this in a feasibility trial of 10 patients that we gave a TEA twice a day for 30 minutes each time for a total of 4 weeks. And we look at different outcomes here. You can see how the worst daily pain and the average daily pain behave over time. And there was an improvement of at 4 weeks at the end of the treatment, and even at the end of follow-up after 4 weeks of having finished the treatment. Now we're conducting a larger crossover randomized control trial comparing this to sham to really understand the efficacy of the device and if it can help patients. Next. Celiac plexus block has been studied in different observational and randomized control trials. And here's a recent meta-analysis that we conducted of 10 studies, and the efficacy of this is only 53%. And when it works, it tends to work approximately for 3 months with an adverse events rate of near 10%. So based on this data, the group at Orlando Health, led by Dr. Wilcox, is leading a multi-center sham control trial comparing celiac plexus block with sham, because such a study is lacking in the literature. And hopefully this will guide us in how to select when to use celiac plexus block in these patients. Next. This is a summary of other studies that we're not going to go in detail, but for example, THC was studied in a phase 2 placebo-controlled trial and showed that it doesn't reduce pain in patients with chronic abdominal pain. Most of them had chronic pancreatitis. Ketamine infusion was studied in a case series conducted at UPMC and showed some early signal that it may be effective, especially in admitted patients. And TPAIT definitely is a treatment that can be effective in selected individuals, and there's going to be a talk about this later today. Next. We cannot talk about refractory pain without mentioning that patients with chronic pancreatitis have many psychiatric comorbidities, and these should be appropriately co-managed during the treatment of pain. Next. Finally, one important aspect is consider empathy when we manage patients with chronic pain. And this was a cohort study of near 1,500 patients with chronic low back pain, in which patients assign physicians to either very empathic or slightly empathic using a validated measure. And patients from physicians who are very empathic demonstrated much better outcomes, like better pain, function, and quality of life. So this is something definitely that we should consider as clinicians when we manage pain with patients with refractory pain. Next. This is a list of the ongoing clinical trials that were in clinicaltrials.gov up to last week. These are different modalities, including medications, cognitive behavioral therapies, devices, and more invasive interventions that are at different stages in the clinical trial pipeline. But we should consider, if we don't have a modality that we can offer to our patients in our centers, to refer patients to clinical trials. Some of these can even be conducted remotely, and your patients may benefit of it. Next. To conclude, about 50% of patients have refractory pain in chronic pancreatitis. It's very important to educate our patients on the pain mechanisms that they may have and validate their pain. It's important to know the therapies that you can prescribe to patients in this setting and to know your team and the therapies available at your center. And if there's a therapy that is not available, consider referring a patient to a center where they have the capabilities to do it, or to send a patient for a clinical trial where they can get additional therapies. And finally, schedule regular follow-up visits and have empathy with your patients. Next. Thank you very much, everyone, and thank you to my team at the University of Michigan.
Again, thank you, Dr. Jorge Macchiato. Next speaker would be Dr. Christine Roberts. She's an associate professor of internal medicine at Ohio State University, and she shall be giving a talk on micronutrient and macronutrient deficiencies and management.
All right, great. Thank you for inviting me today. Just wait here for the slides. All right. Again, thank you to the organizers for inviting me to speak today on micronutrient and macronutrient deficiencies and the management. Next slide. So over the next 15 minutes, I am planning on covering these three objectives. So I'm going to define macronutrient deficiency and malnutrition prior to kind of diving into the literature on dietary patterns in chronic pancreatitis. And then I'm going to summarize some of the available data on fat-soluble vitamin deficiencies in pancreatitis, and then go through some of the treatment strategies for prevention of both fat-soluble vitamin deficiencies and malnutrition. Slide. So the reason why I wanted to start off with defining the terminology is that when you're looking through a lot of literature, even outside of pancreatic diseases, different terminology is often used to describe the same problem. So macronutrient deficiency is defined by inadequate fat, carbohydrate, or protein, but it doesn't necessarily define inadequate caloric intake. When you look at the dietary pattern and there's inadequate caloric intake, that may build into a diagnosis of malnutrition, which by definition is the presence of two or more of these factors that are listed here. So inadequate oral intake or inadequate nutrition support on its own is not enough to diagnose malnutrition. Slide. So now I'm going to walk through a couple papers looking at macronutrient intake. Slide. So this is a paper from our group where we looked at food frequency questionnaire data in 52 patients with chronic pancreatitis and compared to controls. And you can see the first several rows of this table that there's no difference in macronutrient intake between patients with CP and controls, and there was no difference in caloric intake either. Now, if you look down and we started to look at sources of nutrition within the diet, there were some differences that started to appear. Patients with chronic pancreatitis tend to consume fewer servings of fruits and vegetables. There's a trend for higher intake of sweets. And in this particular cohort, although this is not consistent with all studies, alcohol consumption was significantly less in the CP patient population. Slide. So Sinead Dugan's group did a meta-analysis, which included our paper from 2019 and asked similar questions. So this was looking at patients with CP and if there was a caloric difference between healthy controls, and you could see no significant difference in caloric intake. Slide. But then this group went through and further analyzed, and they said, well, what happens if we take out all caloric calories that are from alcohol? Remember, alcohol has about 7 calories per gram, so it could be a pretty significant contributor to calories. So now you can see that the controls were consuming a significantly fewer number of calories compared to patients with chronic pancreatitis. Slide. Their last analysis just looked at the CP group, and they looked based on etiology. So they teased out alcohol-related etiologies versus non-alcohol-related etiologies. And now we're starting to see some pretty significant differences in the dietary patterns related to macronutrient intake. So caloric intake was significantly different, with alcohol-based etiologies consuming 1,000 calories or more per day compared to the non-alcohol-based etiologies. And they were also consuming a higher amount of protein and fat as well. When you actually look at the non-alcohol related chronic pancreatitis patients and you look at their macronutrient intake for protein and fat, we're getting pretty low here. And so when I'm starting to look at some of the outcomes where of concern in this patient population, inadequate protein intake we know can contribute to muscle wasting. We know that inadequate fat intake can contribute to fatty acid, essential fatty acid deficiency and fat-soluble vitamin deficiency as well. But one thing I just want to highlight about some of this data is that often there's different dietary assessment tools being utilized. So that's one thing to think about reading the literature. And also there's a lot of subcategories here as well that are likely influencing how these patients consume their diet. Slide. So we can look at patients with chronic pancreatitis in many of these studies and say that there's a lot of work that could be done to improve the adequacy of the diet, whether it's from a macronutrient intake, micronutrient intake, or just the overall dietary pattern. Slide. So these are many of the outcomes of interest to the individual sitting in this room, and nutrition impacts many of these. And I'm going to focus on 3. Slide. Just for the sake of time, I'm going to move quickly through bone disease and sarcopenia, and due to the objectives of my talk, I'll spend a little bit more time on micronutrient deficiency. Slide. So this is a systematic review that was published looking at the prevalence of sarcopenia in patients with chronic pancreatitis, and it includes 16 studies, over 1,500 participants, and the prevalence rates for sarcopenia range from 29 to 35%, depending on the strength of the study included in the analysis. And if you look in the literature as to some contributing factors, not all are listed here, but inadequate oral intake, which we've just seen in the previous couple papers that I talked about, lack of physical activity, maldigestion, malabsorption, EPI. And then one paper had looked specifically at energy expenditure that I thought was interesting, where patients that had a lower body mass index actually had a much higher than predicted energy expenditure, which isn't really what to be expected, as we know lean body mass kind of drives our energy requirements. And so, you know, we've seen etiology differ based on the way that patients are consuming their diet, and maybe some evidence that body composition is something that we also need to be looking at to help us to understand dietary patterns as well. If energy expenditure is high in select patients, they may be requiring excessive amount of calories and macronutrients to meet that demand to prevent weight loss. Slide. And this is a recent systematic review and meta-analysis looking at bone disease. This had 17 different papers included, over 1,600 participants. And this showed that the prevalence rates were almost 60% in CP. And the authors concluded that body mass index was a contributing factor here, and also some fat-soluble vitamin deficiencies, which I'll talk about in a little bit more detail. But we know from decades of bone literature that the dietary pattern, protein intake, vitamin K intake, vitamin D, calcium intake, all significantly contribute to bone health. Slide. And so because both of those conditions, sarcopenia and bone disease, are impacted by nutritional intake, I wanted to take a little bit of a turn and just define in a little bit more detail malnutrition, because again, this is inconsistently utilized in a lot of literature in all diseases. So this was released by the American Society of Parenteral and Enteral Nutrition and the Academy of Nutrition and Dietetics just over 10 years ago. And it's etiology based. So you can see acute illness and injury is one category. So that might be the criteria that you would use to diagnose a patient that's coming in with acute pancreatitis. Chronic illness, this could be your oncology diagnoses or chronic pancreatitis in this case. And then social and environmental might be your patients that have a history of disordered eating or perhaps food insecurity or availability of food. And then you look at these 6 criteria, and your patient has to meet 2 of these 6 criteria to get that diagnosis of malnutrition. And you can see we've talked about energy intake as far as macronutrient composition, but that alone is not enough to diagnose somebody with malnutrition. So often in the literature, you'll see the presence of one of these criteria as being utilized to diagnose malnutrition, and likely that's a better indicator for risk. We also see, due to history, historically, we used to use serum proteins as markers of malnutrition. So you'll often see albumin or prealbumin being indicated when they're low as a sign of malnutrition. We now know that these are really a relationship to the inflammatory response. You could feed patients adequately during an inflammatory response, and you're not going to see their serum protein levels move until the inflammation resolves. So not sufficient for diagnosing malnutrition. And then micronutrient deficiency is also insufficient for diagnosing malnutrition. We could think of plenty cases of individuals with micronutrient deficiency that don't have malnutrition. And I think vitamin D and iron are probably good examples that we see here in the US. Slide. So to talk a little bit more about vitamin deficiency, that this was the second objective of this talk today. And I'm going to try to summarize the talk that I gave yesterday in just a couple of slides. But fat-soluble vitamin deficiencies are prevalent in both acute and chronic pancreatitis. And there's likely numerous factors that are contributing to the variability that we see in prevalence rates being reported in the literature that you can see that I've included here for both acute and chronic pancreatitis. A couple things to note is that vitamin K is likely the most common fat-soluble vitamin that is eliminated from a lot of studies. So we have the least information about the role of vitamin K deficiency in both acute and chronic pancreatitis, and just encouraging future investigations to include biomarkers of that. Slide. So this is a very brief overview of micronutrient assessment. In any condition, we start with guidelines and protocols to really guide when we should be drawing specific micronutrient levels. And then we look at specific factors for the patient, their medical history, medication use. The nutrition-focused physical exam can help us to identify signs of vitamin and mineral deficiency, but it's also critical for picking up changes in fat, mass, and losses of lean body mass to help understand that diagnosis of malnutrition. Dietary intake and any supplementation that patients are using, whether that's over the counter or prescription grade, and then biochemical assessments as well. Next slide. So this is a table that pulls together the physical findings that are associated with each of the fat-soluble vitamins and the biochemical assessments. And I've highlighted the most common bio assessment for each of the fat-soluble vitamins to consider using in clinical practice and research. But as you can see, for each of these fat-soluble vitamins, there's numerous assays that we can utilize to really paint the full picture of a micronutrient deficiency, as just the biochemical assessment alone is insufficient to do that. Next slide. So this is a table that was taken from an article published a couple of years ago from Meta Berger, who's kind of leading the field in micronutrient assessment. And the purpose of this paper is that she's talking about the role of these highlighted laboratory parameters, except for INR, on the acute phase response. So if you are measuring these parameters and your patient is actively inflamed and has a C-reactive protein above these cutoffs, you're going to see a decline in the serum levels, and that may only be indicative of the inflammatory response and not a true deficiency. So looking through all those prevalence papers of fat-soluble vitamin deficiencies, I didn't come across one study that had adjusted for inflammation. Many studies reported C-reactive protein levels or hypoalbuminemia, which could be a surrogate for inflammation as well, but none of the levels were adjusted. So we know these patients are inflamed. It helps to really understand the prevalence if we include that. Next slide. So 2 questions that I'm just going to review quickly here. One is, does exocrine pancreatic insufficiency impact fat-soluble vitamin status? The studies that are in red show no, there's no evidence within this particular study that EPI does impact fat-soluble vitamin status. But you can see in chronic pancreatitis, we have at least 5 studies that I could find that showed, yes, the prevalence of EPI or the presence of EPI is associated with increased risk of fat-soluble vitamin deficiency. Slide. So also looking at etiology, just a couple things I'll note about this. Not as many papers stratifying fat-soluble vitamin deficiencies by pancreatitis etiology, but vitamin A was identified in both acute and chronic pancreatitis as being associated with alcohol-related etiologies. When you look at other diseases that are associated with alcohol use disorders, you see typical findings of vitamin A deficiency being prevalent as well. Alcohol consumption can destroy retinoic acid. There's also some impacts related to the dietary pattern that may cause patients to be deficient in zinc, which is responsible for retinol binding protein synthesis as well. Slide. So there are lots of different treatment strategies, and each of these could probably be a talk on their own. Slide. But I'm going to focus on just the 2 outcomes that I was charged with discussing today. So what are some things that we can think about for preventing or treating micronutrient deficiencies? I think the first thing that we need to do is routinely monitor our patients. So guidelines will suggest that we should be checking micronutrient levels at baseline and then at least annually. I would agree with at least a baseline and annually assessment as well, unless you're finding any deficiencies from those lab draws. But I think we need to make sure that we're using the correct biochemical assays and pulling together all the pieces of the assessment when diagnosing these patients. It's not until we get the appropriate assessment that we're going to have a better understanding of how these micronutrient deficiencies are impacting many of our outcomes of interest. And then when it comes to repletion strategies, a lot of dietitians will use repletion strategies that have been published in like the cystic fibrosis literature or the intestinal failure literature as a starting point, and then using the biochemical assessments to kind of dictate where you go after that first treatment. But prescription dosing is essential if you are treating a deficiency. Over-the-counter supplementation may be useful for prevention, but you're likely not going to find a strong enough supplement over-the-counter to treat a true deficiency. And also, many of those are not third-party tested, and so the bioavailability may be inadequate for this patient population. For preventing and or treating malnutrition, as we heard from our first talk today, there's a lot of misinformation about diet in pancreatitis. I actually don't even know if it's misinformation. I just don't think we actually know what is best for this patient population to be consuming. But we do know that when patients are told to follow an extremely low-fat diet, they develop more fat-soluble vitamin deficiencies, they increase their risk for essential fatty acid deficiency, and they tend to lose weight, which can lead towards that diagnosis of malnutrition once you start seeing the muscle and fat changes as well. So really you're looking at how can we spread out great sources of fat, poly and monounsaturated fats throughout small frequent meals. But we still need a lot of work to understand how pain is impacted by the dietary pattern. When it comes to patients not meeting their caloric needs, I think we are a little fearful of moving towards nutrition support. It doesn't have to be placing a feeding tube. This could be using oral nutrition supplements or talking with patients about making their own protein shakes. But if we can prevent these patients from losing the muscle, we're going to see these rates of bone disease and sarcopenia improving. So I think we're waiting until these patients are too underweight and then, starting them on these more aggressive therapies. In acute pancreatitis, I think we do a lot better. We're really good at starting early enteral nutrition in the ICU. And we know that this is associated with lots of positive outcomes related to length of stay and decreased complications. Slide. And this is not comprehensive, but this is my last kind of slide on treatment strategies. In the ICU or outside of the ICU, when patients are on nutrition support, we often fear that they're not tolerating their tube feeding. And there have been plenty of studies in lots of different disease states that are starting to get away from just assuming that the tube feeding is going to cause diarrhea. There's lots of different ways that we can approach diarrhea in this patient population, things that we could think about. Soluble fiber supplementation may be a good option by promoting some of the growth of the good microbes in the GI tract as well. And so just things kind of food for thought. Slide. So in summary, nutrition is critical to many outcomes of interest in AP and CP. I would encourage researchers to include an assessment of dietary intake to help us really understand that a little bit more. Lots of different factors that contribute to nutritional status and diagnosing malnutrition. And then remember, if we're going to include fat-soluble vitamin assessments for our patient or in research studies, include a biomarker of inflammation, and take a look at that Metaburger paper looking over some of the other biochemical assessments. Thank you.
Thank you so much, Dr. Roberts. If all the speakers could please come up to the stage and we can take questions. The microphone is here on this side.
I would like to ask the first question to Dr. Roberts. Excellent presentation. One of the points you were highlighting was about essential fatty acids. Dr. Downs and Dr. Belinda Bellin from our group, they looked at post-TPIT patients and they looked at the triene and tetraene ratio and they found that to be deficient in like nearly 1/3 of patients a year after TPIT. And it progressively increases. So we routinely check essential fatty acid in our post-TPIT patients. What are your thoughts about checking them on a routine manner?
There we go. That one on? Okay, I think it's up. I think that's a good question, and I don't think we have scientific data to answer that question. I know a lot of practice in the US with at least dietitians is that if you have a patient that is following an extremely low-fat diet, we do routinely assess essential fatty acid panels. But I think that outside of that, there's been plenty of case studies of patients on an oral diet that are following an adequate fat diet that we're not seeing essential fatty acid deficiency. So I think until we have more data, I would say if your patients are reporting that they're following a low-fat diet, and I think sometimes it's not just your patient saying that they're following a low-fat diet, but it could also be that you're seeing signs of weight loss and muscle loss that would show that they're just not consuming enough. I think those would be good indications for checking them pre.
Thank you all. I learned a lot. I was going to ask a couple of questions. The first is, Megan, if you've gone from NPF center to NPF center and many other places, I was disappointed but not surprised of the fact that you could get a variety of opinions, even at a single center, depending on the specialist you were speaking with. And I wonder, as you think back across that, were there centers that were doing it better And if so, how did they organize themselves, or how did the visit go for you that made that more consistent or led to more harmonious recommendations?
I think the centers that had integrative health programs tended to be better overall. And then within that, some communicated, it seemed, more between the GI docs and the integrative health. And some, that communication seemed a little broken. So I would say not just having that program, but also kind of speaking with one voice or one team.
Thank you. Thank you. Yeah, I'm sort of thinking about my own center, and I think we do fairly well, but it's like, maybe we really don't, you know? And then the question, Christopher, you, and I was hoping you could help me understand this, and that is that when you look at patients with chronic pancreatitis and sort of look at their overall energy and nutritional state, they commonly have elevated resting energy expenditure, and it can be substantial in some studies, 20 or 30%. And my question is, why? Why do they have that?
So I don't know the answer to that, but I know, we have a study going on right now at OSU looking at energy expenditure where we're trying to help understand that a little bit more. Part of me thinks it's the baseline inflammation that we're just not accounting for. Like when we assess energy requirements, typically, other than measuring it, it's really guesswork, right? We're using body weight and we're making a guess. And I don't think that's a really accurate way to determine it. So, but when we measure it, I mean, we're analyzing this now at OSU, but my guess is that probably it has something to do with the inflammatory response, the underlying inflammatory response, and maybe it's just more than we would have anticipated.
Hi there, Walter Park, Stanford. This was a wonderful session. Thank you. A couple of questions are, Kristen, it's point of clarification. When you define malnourished, it seemed to be a change over time. And just, can an overweight or obese person be malnourished if you're intentionally dieting them? Or is that only if after
Yeah.
a certain BMI or certain weight?
Yeah, no, it's not based off of a BMI of a certain weight. So you can have patients that have malnutrition that fit into the overweight, obese, or severely obese BMI categories. I think actually your presentation yesterday on sarcopenia saw that, right? We see sarcopenic obesity, and many of those patients can meet the criteria based off of this. You're usually getting it from muscle loss and inadequate oral intake. So when you look at like a patient population, like let's say patients that get a bariatric procedure, you're looking at the rate at which their body weight is lost over time as being concerning. So even in that patient population, we don't want them to lose 20 pounds a week, because we know if they're losing 20 pounds a week, they're losing lean body mass. Over time, that'll be picked up whether or not you're using a nutrition-focused physical exam or doing imaging to assess that.
So it is a correct statement to say Mrs. Smith, who is obese, is malnourished.
Correct.
You can actually say that. Okay.
Yep.
Great.
And they're often missed. It's the biggest patient population missed, I would say.
Very clarifying. Jorge, I just wanted, this is more of a comment, when you kind of throw up the 50% refractory CP statistic, I think many of us in the room can be like, yeah, I think that's probably true in our pancreas clinic. And yet many of us who have been participating in pain studies, right, are struggling to find these patients to enroll. And it got me thinking about the true nature of that statistic, because we do have a lot of people who come in with pain, but I think in my experience, we are able to, through a variety of the different mechanisms you've kind of talked about, we are able to get that down to a low enough number that it almost defeats our research trials. Like we struggle, for example, we tried to participate in the STEP study, and it was just hard to find these patients, even though anecdotally, I was like, I can remember these patients. But by the time we got to screening them, we had essentially effectively treated their pain, not to zero, but we got it to a point where it was more manageable. So it got me thinking about the truth of that statistic and the durability of it.
Yeah, thank you so much, Walter, for the question. I think that two reasons. One is we don't have a good standardized definition for refractory pain. So, I tried to define it to the best that I could using the literature. Again, if you consider using the conventional therapies that we offer to patients as the marker to say if people fail that, then they will meet a definition of refractory pain. But even in the studies that I show, there were two studies, the one that was conducted here at Pitt, so single center, expert center that sees patients with chronic pancreatitis that were followed for many years. But then despite having been on a decade of follow-up, half of the patient had persistent pain, even having received interventions, having received opioids. And then if you look at the ESCAPE trial again, that well-selected patients that you're doing a ductal drainage procedure, and this is like rigorous randomized controlled trial, still 50% plus of patients had pain up to 18 months of having had this intervention. So I think that definitely we need a better definition of this that we can work with within studies, because if we're going to enroll patients in trials, it depends at what point within the natural history of the disease we're enrolling them. And I think that, if you consider this definition, it's probably, near 50%, like within a range, but it's going to depend in the center where you are, the treatments that they have been exposed, and like a variation within what your expert has had to offer them over time. I think there's not a single solution for pain. It's going to be like tackling different mechanisms with different therapies within the individual patient and progressively being able to decrease their pain over time.
So we're at time, but perhaps we'll go 2 minutes over to allow for these two questions. Thank you.
All right. Quick question for Jorge. Anecdotally, a bunch of my patients have been asking me about scrambler therapy recently after that New England Journal paper came out a couple years ago. I had a question about, are you incorporating scrambler therapy into your practice, and how do we get trained in that or offer it clinically?
Sorry, can you repeat what therapy, Sam?
Scrambler therapy?
Yeah. Thank you about that. So actually, there was a talk about that yesterday from the group at Hopkins that they're doing like a clinical trial that was conducted within near 20 patients that are almost close to finishing the trial. And there seemed to be like a good response within this open label clinical trial. Again, this needs to be confirmed into a sham control trial in the future. At this point, at my center, we're not doing that. And I think that is a promising technique if you consider that within a clinical trial framework.
Very quickly, just two things. The first one is with pain therapy. If you put everybody into the same pain bucket, there's going to be so much heterogeneity, you can't sort it out. What we found using an APS-2 study is if you do a nested GWAS with people with severe pain versus mild pain, almost all of the signals are in the spinal cord, peripheral nerves, and brain, which overlap with other chronic pain syndromes. So targeting the pancreas is going to miss the problem in most cases unless you can sort that out. And I know Anna Phillips has done a lot of work with the quantitative sensory pain testing, which helps sort that out. So rather than a question, I'll just leave it there. The other question or comment I had is that the work of Roger Little in looking at phosphate deficiency in alcoholics and how that is involved in so many aspects of severity and progression. Should we be looking at this, and is there a good way to assess whether or not there's a phosphate deficiency and how to replete it?
So the phosphorus deficiency, I think what you're probably referring to is like a lot of the refeeding papers, right? Which is definitely a risk factor for any patient that's actively consuming alcohol, and other reasons as well. Like the homeless population is a big concern. Even some athletes, disordered eating patterns, big concern. I mean, obviously we have the laboratory value that is available, but I think it's so dependent on kidney function and your hydration status that I don't know if we would see a lot of need for like additional supplementation of it. Is that what you're referring to, is to know if we need to supplement?
Well, in animal models, if you deplete the phosphate and you give them pancreatitis, it's extremely poor outcome. If you replenish it ahead of time, you have mild pancreatitis. If you take it to the clinic, the alcoholic subset seems to have this deficiency, and it's not just refeeding syndrome, it's pancreas deficiency, and you can't pump the calcium out, and it's an energy problem.
Mm-hmm.
But it can be prevented, or, and I'm not sure if that's something that we should do regularly or if it's just, you know.
Yeah,
part of the
I don't
diet.
know if I have a good answer to that, other than I think, like we could see similar studies, right, with vitamin D deficiency being associated with severe acute pancreatitis in the ICU. I think inadequate oral intake, inadequate dietary exposure is a risk factor for, not being able to support your immune system. So my guess is that it would be great for us to know those patients and be able to treat them. I think if we could just get people eating, and I think that goes back to the point of, not shying away from using nutrition support. If we're seeing our patients are going down the wrong path, nutrition support is going to give them phosphorus and the vitamins and minerals that they need to support their immune system.
So the answer is we really don't know. It's an important area we should probably work on.
Yeah, great.
Thank you so much. That concludes our session.